Welcome, everyone. So we have a lot to cover today, as you might imagine. I'm going to go ahead and get started. I'm Max Crowley, a prevention scientist and associate professor of human development and family studies and public policy at Penn State University. And I'll be serving as our MC for the webinar today, called From Programs to Policy, the Role of Economic Evaluation in Prevention. We'll be discussing different types of economic evaluation and how that work can help decision makers to fund programs in their implementation as well as scale up. We can go ahead and move to the next slide. So we have 3 learning objectives today. 1, to introduce economic evaluation and its purpose to everyone here. 2, to promote a practical understanding of economic evaluation in the context of the HEAL Prevention Cooperative. And 3, to impart knowledge on how economic evaluation results can be used in decision-making and broader program adoption. We can move to the next slide. So the Helping to End Addiction Long-Term, or HEAL Prevention Cooperative, or HPC as it's sometimes called, is part of the broader HEAL Prevention Initiative. It's composed of 10 research projects and 1 coordinating center and is funded by the NIH and NIDA. The overarching aim of the HPC is to develop and test 10 interventions to prevent opioid misuse and opioid use disorder among young people. The collaborative nature of the HPC helps to ensure comparable methods for example, outcomes assessed or that are being assessed are used across projects. We can move to the next slide. So at a really basic level, all individuals, of course, start out not misusing opioids. Then at some point, some people do start misusing opioids. And then for some who misuse opioids, they go on to develop what is known as opioid use disorder. Effective prevention works by disrupting this progression and has the potential to save lives and reduce personal as well as societal costs. So the potential for impact is huge, as you might imagine. Simply based on the National Survey of Drug Use and Health numbers from 2020, we can consider that 9.5 million people 12 or older had misused opioids in the past year, and 2.7 million had an opioid use disorder. We move to the next slide. So this figure represents the continuum of care, the care continuum, and the various points at which the 10 HPC projects are reaching people. While one project is engaging in health promotion, most projects are either in the selective or indicated prevention space. Next slide. So the research projects are using what is known as activity-based costing, or ABC, which involves decomposing the relevant costs into predefined activities and then measuring the quantity and unit price of each resource. It is a precise way of measuring cost, and research projects are using it to measure the startup as well as the intervention delivery costs. Startup costs measure the resources used to prepare to deliver the intervention, whereas the intervention costs measure the resources used in delivering that intervention. Next slide. So cost effectiveness analysis, or CEA, is a comparative analysis that is about comparing an intervention with an alternative. The analysis examines differences in intervention costs per unit of a desired outcome. For example, research projects in the HPC are looking at differences in the cost per prevented initiation or prevented escalation, where escalation is often defined as more frequent misuse. So this analysis is important to understand the economic value of an intervention. Next slide, please. So budget impact analysis, or BIA, estimates the impact of funding on for an intervention on a decision maker's budget in terms of the cost expenditures. The estimates account for the desired scale of the intervention and the target population using a time frame of no more than 5 years. BIA results are increasingly being used alongside of cost effectiveness analyses to inform on the affordability of interventions in question. Next slide. So as with all funding decisions, there are resource constraints for prevention programs as well. When choosing among a set of preventative interventions, CEA cost effectiveness analysis, and BIA, budgetary impact analyses, help the decision makers to choose the efficient, affordable programs that can be funded. And a decision maker may have additional factors of consideration, as you might imagine, in such decisions, such as the subpopulations of interest that need to be targeted. Next slide, please. So now I've very briefly introduced the HPC and economic evaluation tools, including activity-based costing, cost effectiveness analysis, and budgetary impact analysis. Our esteemed speakers that follow will go into more detail about all of these topics and will show their application in the HEAL Prevention Collaborative. So next we have Catherine McAllister from the University of Miami discussing activity-based costing, Margaret Kuklinski from the University of Washington discussing cost effectiveness analysis, and Olga Kavjo from RTI for discussing budget impact analysis. All of today's speakers will engage in a panel discussion on the role of economic evaluation and prevention to be facilitated by Sarah Duffy from NIDA. The panel will also be joined by Laura Dunlap from RTI, who leads the economic evaluation team at the coordinating center. So during the panel discussion, audience members will have the chance to ask questions to the panel over chat. Next slide. Finally, for more information, you can sign up for the HPC listserv and visit the HEAL Prevention Initiative website. We will also drop these links into the chat. So now I'm going to pass the mic over to Catherine to talk about activity-based costing.
Thank you, Max. Hi, everyone. My name is Catherine McAllister, and I'm a professor at the University of Miami Miller School of Medicine in the Department of Public Health Sciences. And as Max said, I'm going to talk a little bit more with you about activity-based costing. Next slide. So a cost analysis serves as a foundation for a full economic evaluation where we're comparing costs to some outcomes, some measures that can reflect effectiveness or benefits or utility. And we put cost data together with those measures, we can perform the full evaluation that would be a cost effectiveness analysis, cost benefit analysis, or cost utility analysis. In collecting cost data, often this is alongside a randomized trial focused on testing effectiveness. We can select different methods which vary in precision, and the most precise method is called microcosting or activity-based costing, where the resources invested in implementing an intervention are quantified and then valued using resource unit prices. Less precise methods include relying on annual budgets or aggregate expenditures. Sometimes we say a top-down approach to estimate intervention costs. The analysis perspective is important for determining what prices are relevant and what resources are relevant. We can look at costs from multiple perspectives, and this is recommended by the second panel on cost effectiveness in health and medicine, which recommends looking at costs from both the healthcare sector and the societal perspective. And when dealing with prevention programs, other perspectives like something a little bit more narrow, like the payer perspective, can be very important. This could be framed from, say, the state or taxpayer perspective, for example, depending on the program. We're also interested in the societal perspective, which is broadest and includes things like subsidized or donated resources. Next slide. So to understand a little bit more about the intervention costs that we consider, we like to categorize things as you see in this table. And so we have startup costs, which are generated by pre-implementation required activities, things like hiring, onboarding of staff, training, sometimes infrastructure and investments. These costs are important for stakeholders who are thinking of adopting a program from scratch. But we don't actually include startup costs in a cost effectiveness analysis because startup costs are what we think of as being sunk costs, which will have to be incurred regardless of how many individuals ever receive an intervention. So then post-startup, so post-implementation of an intervention, we have three categories of costs that we're interested in. So for intervention costs, we focus on time-dependent costs. As that term implies, these are things like that vary with time, that recur over time. And it's typically things like leasing costs for buildings or facilities or other types of equipment. Then we have variable costs, which are based on the number of individuals receiving the intervention, and some examples are things like staff or supplies or medications. And finally, economic costs, which are important for the societal perspective that I mentioned and represent subsidized and or donated resources. Next slide. So this slide describes the process of calculating costs with examples of what we mean by different types of resources and price weights. So for example, an important resource is staff time, or in this case, staff hours, for example, in training. And this is obviously would be compensated through wages. So we track hours of staff time and apply an hourly wage that's appropriate for the position. This may vary, of course, depending on the analysis perspective. Next slide. For all intervention phases, the process as far as activity-based costing is essentially the same, in terms of thinking about how to quantify resources and valuing them. The difference comes in how we express or summarize costs. So startup costs are calculated as a total cost during a defined startup period, and implementation costs are estimated per study participant, preferably at the individual participant level. Also, with implementation costs, we have different categories of cost. So I mentioned time-dependent and variable, for example, which reflect the ongoing management costs of running an intervention. So that's an important estimate to give an idea of what the average cost is of operating an intervention over time. Next slide. I'll talk briefly about one of the HEAL prevention studies that I am aligned with, which is called Preventing Opioid Use Among Justice-Involved Youth as They Transition to Adulthood, Leveraging Safe Adults, or LISA. So this study is based at Texas Christian University, TCU, and the principal investigator is Danica Knight. This study is focused on opioid prevention, assisting justice-involved youth in developing relationships with safe adults who serve as guides and mentors. The intervention is called Trust-Based Relational Intervention, or TBRI, which uses a youth-centered, attachment-based and trauma-informed approach to strengthen youth safe adult relationships and also to improve youth self-regulation. This study is a a hybrid type 1 effectiveness implementation study where phase 1 focused on the adaptation of TBRI to this setting, juvenile justice setting, and phase 2 is the comparative effectiveness trial. And the comparisons are between TBRI training only, TBRI training plus structured coaching, and TBRI training plus responsive coaching. So this is really focused on comparing different coaching support formats. It has a delayed start design, 3 waves, and an 18-month follow-up. Next slide. So for the activity-based costing of LISA, we have focused on these categories that I've mentioned before. So startup, which is mostly planning and management meetings, training, hiring, and intervention development and adaptation. For intervention delivery, we are focusing on things that are required to have the TBRI sessions, including scheduling and preparation of sessions, post-session follow-up, and travel and time in sessions. And then sustainment for this intervention is really looks like transferring the TBRI training to the juvenile justice agencies. So the agencies themselves would hire a TBRI certified coach to work with these youth. Next slide. Because staff are important in these interventions and labor costs tend to dominate total intervention costs, this slide gives you an idea of how we approach valuing time. The HEAL initiatives involve many states and locations, and cross-study analyses are planned. So we think quite a bit about the best sources of data to value time. And one source that's quite good is called ONET, which is based on, it's supported by the Bureau of Labor Statistics and based on national surveys of occupations and salaries. And the process we underwent here is we mapped positions and occupations that were part of the intervention onto ONET classifications in order to get wages. And ONET gives both state-specific and national salaries. So we were able to use that data to then come up with an hourly wage that's representative of these positions that were involved in the interventions. Next slide. So in summary, activity-based costing is a precise micro-costing method for estimating intervention costs, and it is important for measuring and valuing time and resources. Startup costs are presented as total cost, as I mentioned, during a startup period, whereas intervention costs are presented as a per participant cost that varies at the individual level, and it really is based on that variation is based on intervention engagement. Per participant costs can be compared to individual outcome data, and that's where we're able to do the cost effectiveness models, which you'll hear more about in just a moment. Next slide. Thank you. I'm going to pass the baton to Margaret Kuklinski.
Thank you, Catherine. And you can go ahead to the next slide. I'm Margaret Kuklinski. As Catherine said, I'm from the University of Washington Social Development Research Group. And in the next 10 minutes, I'm going to recap cost effectiveness analysis, hopefully bring it to life using an example from the POST study, or preventing opioids through successful transitions, and wrap up with just a couple thoughts on the utility of this information for dissemination and implementation of effective interventions. Next slide. So like other health economic evaluation methods, cost effectiveness analysis is a decision-making tool by looking at both costs and outcomes, not just the cost side, but both. It helps decision makers understand which policy, program, and in the case of this presentation and project, interventions are good investments from an economic perspective. Next. So specifically, cost effectiveness analysis helps us understand the intervention cost per unit gain in a desired outcome. In the HEAL studies, those desired outcomes have to do with opioid use, but the method is actually really flexible and can handle a number of health, behavioral health, and other outcomes. To evaluate cost effectiveness, we use the incremental cost effectiveness ratio. And I hope from looking at the formula, you can see that this is an inherently comparative method. Generally, we're looking at a specific intervention and trying to determine if it's a good investment compared to an alternative that could be another intervention option, or it could be a business as usual control condition. So we look at the difference in costs and divide that by the difference in impact. And if that ICER is pretty low, that's generally a desired outcome. How do we get a low ICER? Well, we get it if the intervention that we're interested in doesn't cost much more than the alternative, or if it has a bigger impact, excuse me, a relatively big impact compared to the alternative, or, excuse me, some combination of the two. If those ICERs are less than what decision makers are willing to pay to improved outcomes, we have an indication that the intervention that we're interested in is cost effective. Now, of course, non-economic factors, things like equity, values, resource constraints, and other things are also big drivers of policy decisions. Cost effectiveness information is just one aspect of the tools that are available to decision makers. Next slide, please. So the example that I'm going to give is from our HEAL study, in which we are trying to develop effective interventions to prevent opioid use disorder in young people who are incarcerated. There is a great need to do this. We don't have too many effective interventions, but we know that 20% of those young people who are incarcerated already suffer from OUD. We also know that interventions that increase skills and also increase relationships, social connectedness, can help prevent OUD and also return to landing in prison. What we don't know is how intensive intervention supports need to be effective. Next, please. So in the POST study, the team is trying to identify both effective and cost-effective intervention approaches to reducing opioid use disorder in a sample of about 400 people between the ages of 16 and 25 who are incarcerated in the state of Washington. This trial uses a SMART design, and I'll say more about what that is in a minute. But again, our objective is to understand which interventions, how intensive do they need to be effective and also cost effective. Next slide. Just to say a little more about these interventions, we're using the evidence-based adolescent community reinforcement approach, also appropriate for working with young adults. And it involves one-on-one intensive coaching and case management aimed at building skills and relationships that ultimately make the non-use of substances, including opioids, more rewarding to young people than using them. As I mentioned, we've got interventions of different intensities in this trial. The intensive version, or enhanced ACRA, or EACRA, involves a full 6 months of intervention with young people, both before release from confinement and after. And it includes ACRA supplemented by a trauma-focused intervention, because trauma is such a big part of the histories of young people who are in prison. The less intensive version, or ACRA Light, involves 3 months of intervention, 4 weeks of ACRA prior to release from confinement, and then 8 weeks of case management afterwards. We're also tailoring those interventions to the risk level of youth at the start of the trial. So the high-risk group of youth are those who have a prior substance use disorder. They'll be offered EACRA or ACRA Light. Those who don't have a substance use disorder will be offered ACRA Light or business as usual control, because we think that with this group, a less intensive form of intervention is warranted. Next slide. So our main question is whether investment in more intensive interventions is worth it, again, from an economic perspective. For young people who come into the trial with a prior substance use disorder, we'll be asking whether investment in intensive ACRA, the EACRA version, is cost-effective compared to ACRA Light. We'll have to estimate an ICER. That's going to involve using the activities-based costing approach that Catherine described to estimate the costs of both EACRA and ACRA Light. We'll look at the difference and divide that by the difference in impact of EACRA compared to ACRA Light, and we'll get the impact information from the study team. We'll actually calculate 3 ICERs because we have 3 primary outcomes, and we'll compare them to willingness to pay estimates. And if our ICERs are lower than those willingness to pay values, we'll have an indication that EACRA is a good investment. It's cost effective in relation to ACRA Light. And we'll do some sensitivity analyses because of uncertainty in these estimates too. Next slide, please. Because we have a smart design, we actually can learn so much more about intervention impact and cost effectiveness in this trial. Let me tell you how that smart design goes for us. So our first randomization occurs at stage 1 or baseline, but 4 weeks later, we potentially re-randomize young people to stay in the same intervention condition they're in or to change. So in that way, we've got sequential, multiple assignments, both of which are randomized. Next, please. For young people with prior substance use disorder, at the beginning, they're randomized into EACRA or ACRA Light. And regardless of what happens next, this is the basis for a primary cost effectiveness analysis. Next, please. After 4 weeks, those young people who have landed in EACRA will be re-randomized. Some will stay in EACRA, others will go to ACRA Light. This allows us to answer the question of whether intensive intervention leads to greater impact. And even if it does, is it cost effective? Next, please. For those in the ACRA Light condition, re-randomization at week 4 is going to be based on their use. Those who we have indications of illegal or problem use will be re-randomized potentially to EACRA or to stay in ACRA Light. So here we can answer when an intervention is ineffective, does increasing intensity strengthen impact? And again, even if it does, is it cost effective? Next slide, please. So from our smart design at the end of the trial, we'll have a wealth of information that can help us understand what it takes to build capacity in juvenile justice systems to implement ACRA-type interventions and what it costs to deliver them once a steady state and capacity have been achieved. But we'll also know information about which interventions are effective and for whom, and which are cost effective. And all of this information can help decision makers in future implementations invest at a level capable of achieving impact, and also know how to intervene with which populations to try to reduce the high rates of opioid use disorder in this population. Next slide. Thank you, and I'll now pass it to Olga.
Thank you, Margaret. Hello, everyone. My name is Olga Havju. I am a health economist at RTI International, and I'm leading the subgroup that is working on the development and building of the budget impact analysis model for the HEAL Prevention Initiative. So that's what my part of the presentation will cover today. Is I will describe what the budget impact analysis is and how we're using that for this specific project. So on the next slide, we start with the introduction to budget impact analysis. So this type of analysis, it is an essential part of a comprehensive economic assessment of public health interventions. As Margaret just described, cost effectiveness analysis is where you compare costs and benefits of competing intervention. And that type of analysis is an important criterion for priority setting decisions. However, cost effectiveness analysis does not produce results that can be used to assess whether the interventions that are found to be cost effective are actually affordable by the organization that is interested in implementing those interventions. And that is where the budget impact analysis comes in, because it addresses this specific issue of affordability. And as a result, it is often, or it is increasingly used as a complement to the cost effectiveness analyses. It provides a framework that allows a user to assess how varying assumptions of the intervention's diffusion or scale up will impact things like changes in program intervention costs, changes in the number of cases of this specific condition, as well as changes in the costs related to that specific condition. So as a result, budget impact analysis is really useful in budget planning, forecasting, and meeting health targets. So on the next slide, we talk a little bit more and compare the two types of analysis, budget impact and cost effectiveness. So I will be referring to cost effectiveness analysis quite a lot throughout this presentation. So I'm going to use the acronym of CEA when I talk about cost effectiveness analysis. So these two types of economic analyses have overlapping data requirements and components. However, there are some differences as well. And specifically, perspective of the analysis is one of the differences. In budget impact analysis, the perspective is the one of the payer or the budget holder. So you really are looking at the costs and the benefits that are accrued to the payer of the intervention. Where in cost effectiveness analysis, the recommended perspective is often the societal one, which is a combination of all of the perspectives. Time horizon is another difference between these two types of analyses. In budget impact analyses, we usually use shorter term horizon, 5 years or less, where in CEA, the time horizon for the analysis is usually much longer term. The comparison groups of scenarios are also different in the two types of analysis. In BIA, the goal is really to understand how an introduction of a new intervention will impact, it is in comparison to what is being offered currently. So what is the current mix of the programs or the interventions that the payer is implementing? Where in CEA, the comparison group is defined by researchers. Because there's overlap in these two types of analyses, the data that are being collected for one can also be to a certain degree used for another. So specifically, if you're already doing a cost effectiveness analysis, the marginal cost of conducting budget impact analysis as well is relatively low, because they're only, you don't have to start from scratch and you already are can utilize some of the data that is being collected. So on the next slide, we talk a little bit more about the specific approach that we're using for the HEAL Prevention Initiative when it comes to the budget impact modeling. So as Max noted earlier in his part of the presentation, there are 10 research projects that are implementing different interventions. So our goal is to create a model, a budget impact model that will accommodate all of the interventions that are being assessed by those research projects that are found to be effective. So kind of at the start of the model, the user would be able to select which of these interventions that they're interested in assessing, given their setting or their target population, for example. Like I mentioned, we will be using a lot of the data that is already being collected for CEA, and then we'll also obtain some additional data inputs from research projects as well as the published literature. We will include sensitivity analyses to assess how changing some of the assumptions about the intervention scale up would affect our results. And then we plan to develop a manuscript describing our model and findings as well. On the next slide, we present a graphic that shows the steps or the process for estimating the budget impact. And in this graphic, the 3 distinct buckets are the 3 different years for this analysis, for the budget impact analysis. Like I mentioned earlier, usually the time horizon is 5 years or less. In this example, we're just showing 3 buckets, so 3 different years. So in each year, you start at the top of the funnel where you look at your total population. So this is the total population that is served by the specific payer that you're looking at. And you then apply the eligibility criteria or requirements for participation in the specific program that you're evaluating to that population. And that's when you start to narrow down your target population and your eligible population. And then you determine, that helps you determine who will be participating and who will be impacted by the intervention. And then once you determine that, the next step is to look at what is currently being offered by the payer as far as the interventions. And will this new intervention be an add-on or a replacement to what is currently being offered? If it's an add-on, how is adding this program going to change the distribution of who is participating in which of the interventions? So once you have an understanding of that, kind of the next steps are to look at how intervention costs are changing as the new program is being introduced, as well as how are the condition-related costs changing. And when you combine the two, that will produce the total impact on the budget and show you the changes in annual budgets, as well as annual health outcomes. On the next slide, we are presenting some examples of what results or output could look like in a budget impact evaluation or budget impact analysis. So the 3 different graphs here, the graph on the left shows the changes in intervention program costs. The middle graph are the condition-related costs, and then the graph on the right is the total costs. Each of those, the results are presented for each of the year of the analysis. And then the bars, the solid dark purple bar on the left, that shows what the costs would be if this new program was not introduced. And then the bar right next to it, kind of the checkered or hashed bar, shows what the costs for each of these components would look like if this new program is offered in each of the years based on the assumptions of scalability or diffusion of this intervention. So it's just we wanted to share some examples of what the results will look like. And then the total costs, the graph on the very right side, that's where you can see the impact on the budget overall. The next slide briefly describes the data source, the data elements that we're using, and then the data sources. And I mentioned this earlier that some of our data inputs will be coming from the cost effectiveness analyses, and then others will be obtained from research projects as well as published literature. So to conclude, on the next slide, what we wanted kind of to reiterate is that the budget impact analysis allows users to assess the impact of the intervention scale up or diffusion on its affordability. It is analysis that is complementary to cost effectiveness analysis, and it really allows you to understand whether an intervention that is deemed to be cost effective is also affordable. And kind of our objective with this project, with the HEAL Initiative project, is to produce a model that payers can use to understand how selected interventions will affect their budgets as well as health outcomes. So I will now pass it on to Sarah. Thank you very much.
Thanks so much, Olga, and everybody for these wonderful presentations on the 3 types of economic evaluation that were covered. I'm Sarah Duffy, Associate Director of Economics Research in the Division of Epidemiology Services and Prevention Research at the National Institute on Drug Abuse. I'm delighted to monitor this panel and discussion of our speakers, as well as Laura Dunlap, the Vice President of Community Health Research Division at RTI International, and as mentioned, the leader of the HEAL Prevention Cooperative Coordinating Center Health Economics team. The panel will focus on the real-world value of economic evaluations, exploring how its results can be used to support decision-making by program providers and policymakers. I've got a few questions to start us off, and we welcome questions from the audience. Please put your questions in the Q&A. And so just to start off, we actually did get one question that I want to get to, but just to start up, sort of the basic things. So Margaret, I'm wondering, can you give me an example or two of when an economic evaluation affected a decision on funding for a prevention intervention or set of interventions and how it informed that decision?
Sure, I can give an example from Washington State where I work, and we're actually a state that is pretty rich in the use of economic evaluation information for state policy decision makings. The information about program costs and benefits is part of the criteria for who's eligible for state funding. So that's one sort of general example, but more specifically, it's probably close to 20 years now since Washington was considering investing in a new prison. And work done by the Washington State Institute for Public Policy, who's a leader in benefit cost analysis. We didn't talk about that today, although Catherine mentioned it as one of the economic evaluation types. Basically, we're looking at the long-term benefits of an intervention in economic terms compared to costs. So Washington State was trying to decide whether to build these prisons. And they realized that an alternative to building more prisons was to invest in prevention programs, because prevention programs can also help reduce crime and lower the need for prisons. And so WISIP did an extensive analysis of the costs and benefits of both policy options. And at the end of the day, they concluded that investing in prevention, and I'm sorry, I don't know the specific programs, but that was a better thing from a taxpayer and total state perspective to do than to build more prisons. So that's a real world example of economic information really influencing policy decisions statewide.
Great, thanks so much, Margaret. If anybody else has any other examples of that, feel free to chime in, but let me move to my second question, which this one's for Max. Max, who are some of the decision makers who use economic evaluations or could use them? And what aspects of economic evaluation seem most salient to them in your experience?
Yeah, definitely. It's a good question because often when we think about decision makers or policymakers, everyone has sort of an idea in their head, but there's really a lot of variety out there, not only in terms of the level of government, but also in terms of the area and in the focus. And all of it comes down to what levers they have at hand. And so in particular, when we think about what types of economic evidence really resonates with policymakers, we've done some work within our group in terms of messaging, right? Prevention, particularly substance misuse prevention, as well as others such as the work of Jonathan Pirtle at NYU that I suggest folks check out, specifically looking at what types of cost and cost benefit, budgetary impact, as well as cost effectiveness analysis, how does it resonate? How do you message it? And core to that is being able to provide
quality estimates about what does it cost, right? Because that's always the first question. And then from there, what is the value of it? And it doesn't always have to be contextualized in terms of dollars, right? That's where cost effectiveness comes into play. But having that budgetary impact evidence is extremely valuable. Further, how you message the uncertainty in that information is key for how you engage decision makers. They know that you don't have a crystal ball, and so they want to understand, well, what could go wrong and what could go right. And so being able to come and provide different scenarios is key in terms of how we describe not only the estimates, but the science itself.
That's terrific. Margaret, I saw you shaking nodding your head. Is there anything you want to add to that?
I probably noted at various points. I think that costs, those always feel salient to me. The other thing Max talked about, the uncertainty. Again, WISIP, the Washington State Institute for Public Policy, if you haven't looked at their website, I highly recommend it. They also are really clear in their messaging around uncertainty, and they help decision makers not get lost in the methods for estimating uncertainty or the results, but to be able to have a sense of how likely is it that this will be a good investment, or how risky is it? That's something that I think policymakers can grasp.
Wonderful. Great, thank you. And my next question has to do with the role for research. I'm from NIDA. I'm always interested what research should be looking to. And what's the role for research in increasing the utility of economic evaluations and prevention interventions for decision makers, or in the way of findings are communicated? And Catherine, I wondered if you'd start on this, and then maybe Olga would have some more things to say.
Yeah, I mean, I think this can be challenging, but I really think that the dissemination process, as far as increasing the utility of our findings, is key. And it's really about thinking about the timing and the presentation of results. And so we've brainstormed with some of my research teams about, in addition to manuscripts in scientific journals, which take a long time, there could be other mechanisms like op-ed pieces or white papers, or being a guest on a podcast or something like that, which is really more producing the results in real time, and something that decision makers may find easier to digest than waiting for a big paper to come out. So there's a lot of thought that goes into how we disseminate results. And also what types of things. So an executive summary may be a lot more impactful than, a long methodological paper. So, again, back to thinking about different products that we can produce from our research that aren't just scientific papers. And yeah, so maybe others have thoughts.
Olga, did you have any additional thoughts?
I would completely agree with Catherine, and I was going to say the same thing. We're all, as researchers, get very excited when we get our publications out, but the reality is the decision makers do not, unfortunately, often read peer-reviewed publications.
They don't have time. They've got other things to do.
So we have to be creative and innovative about ways that we can reach those decision makers with our information. Social media, I don't know. Create TikTok videos, I'm not sure. But there are definitely
TikTok videos.
Yes. I'm not suggesting that. But we have to be more intentional about disseminating our results and making sure they get to the right people. And also, like Max and Catherine already noted too, is how do we message and communicate it, right? We can't really write out a technical piece that nobody would ever be able to understand. We need to put it in a language that is accurate, but is also easy enough to understand by others to get our message across. I don't know that I have any great suggestions on how to do it, but I think it's definitely something that we need to be working towards.
Well, great. Max, did you have something to add?
Yeah, I think I want to emphasize what everyone said so far, and really also though highlight it's a relational process, right? Many of us and many of the folks here today are working in behavioral spaces, supporting the development or change of individuals. And how we support and communicate our work is also a behavioral process. Getting decision makers to use the science is a behavioral outcome in and of itself. And there is work and there is a science to scientific impact that can be used. So there are a variety of strategies, some of which are the traditional ones that we've already heard from today, but there are also ways of thinking about how does the scientific community bridge the gap between the decision-making groups and the science.
Great. Great, thanks for your comments on that. Now I want to turn, we do have a couple of questions in the chat. One of them, Catherine, you already answered, but I wondered if you could maybe expand upon it a little. Let's see, I had it written here. Okay, so the question was, thanks for the presentation. Can you talk a little bit about how shared startup costs are allocated to trial arms or individual participants? And what about arm-specific startup costs? Can these be allocated to individual participants? I think it's a way to expand on, the sort of the difference between startup costs and other costs.
Yeah, so my response was basically, we don't really think about allocating startup costs down to the individual level because they're not factored into to the cost effectiveness analysis. And so it's really sort of an aggregate measure of this is what you got to come to the table with in order to implement an intervention. I'm curious to hear how others feel, but I know in the case of the study that I discussed, Lisa, we have 2 experimental conditions and then sort of a standard practice control. And in this case, we would allocate startup basically equally across the 2 experimental conditions because the flow, one of the benefits of activity-based costing is that you can really precisely see what's going on behind or in this pre-implementation startup phase. And so in the case of the Lisa study, I could allocate those startup costs equally. But there may be other examples that some of the other panelists can offer that where they've done something differently.
Go ahead, unmute yourself if you've got anything to say.
I think, Catherine, I fully agree with what you're saying. Based on the question in the chat, I'm imagining, say, a 3-arm trial where one of the 2 arms requires much more intensive intervention and maybe much more training. In that case, you might want to say the startup cost to do this or this, and the startup cost to do that or that. So again, it wouldn't get down to the participant level, like Catherine said, but would acknowledge the different resources required to prepare for a more or less intensive version. So I could imagine that.
Great.
And I was just going to jump in that from the perspective of the budget impact analysis, we do want to include those startup costs because they're relevant for that type of evaluation, although the per participant cost really will depend on the participation rates. And that's a kind of one of the advantages of, or one of the features of the budget impact analysis is once you vary those assumptions of how many people are participating in your intervention, it helps you understand whether or not you can afford it.
Great, thanks so much. It was a good question and great answers. Thanks so much. Another question in the chat is, do you believe that using international certified prevention specialists who are SUD subject matter experts could positively improve prevention program outcomes, reduce costs, and improve effectiveness? Does anybody have any thought about any of that? From, say, some of your prior studies or anything that, Max, go ahead.
Yeah, so I mean, I think it's a complex question, especially when we think about across international settings. But I think that the opportunity to support and further the professionalization of the substance misuse prevention workforce is key. Many of the studies here think about these workforce elements and are pulling from all sorts of different spaces. And many of those implementers, are to become trained in the model over the course of implementation, but they don't start out that way. The opportunity to lower the bar for startup costs for any individual intervention by having more professionalized workforce, could be incredible. of course, but at the same time, that's a systemic change that we need to see, meaningful incentives across the economy for, and internationally in particular, especially in the global South.
Right. Others, any other comments on that? Okay, hearing none. And then somebody, this isn't really a question, but somebody mentioned that the new HEAL Research Dissemination Center program that will be created out of Duke can help with this issue. And I think they meant the dissemination issue. Okay. So other thoughts, people? Oh, I would like to think so. Other thoughts that people have, either expanding on some of the original questions, or maybe you have questions for each other.
Hi, Sarah, this is Laura.
Hey, Laura.
Hey, I guess I just want to build off actually the first question, which Margaret gave a great answer to, which is how can the economics help inform decision making? And I guess one thing I would raise is, that's a challenging question, because we actually don't see economics data being used in prevention in this way a lot. So I think that as researchers, it would be great to see more partnership, if you will, across these disciplines to bring forth not just economic data, but there's multiple types of data that we need to make sure that our policymakers have to make informed decisions. So I just wanted kind of to throw that out, that there actually aren't that many examples where we're seeing that direct of a link between the use of economic data and then the policymaking decisions, at least from what I've seen in the prevention space. I don't know, Margaret, if you want to chime in more on that.
Yeah, I want to chime in on the point of relationship building, because it's not as if this strong health economics ecosystem in Washington State happened overnight. It was long-term relationship building and good work, sort of high quality, trusted work, trusted broker, WISP being that trusted broker and doing exceptional work in Washington State that made the legislature over time increasingly comfortable, increasingly knowledgeable and interested. The idea of getting to better outcomes at lower cost, knowing what was a good use of taxpayer dollars, those are such critical real world questions. But WISP has been investing in those relationships now for a long time. So I guess the message is just begin, start small, keep going. Max, I wonder if you have anything to add to this about supporting states in their work.
Definitely. Thank you, Margaret. And I think Washington State is such an excellent example because it has decades of sort of success behind it in many ways of leading in this area. Through the support of the Pew and MacArthur foundations, there's been efforts to bring that model to other states. And that work has recently migrated to our center here at Penn State, working on trying to bring a similar model to state legislatures and agencies across the country. It's been a very interesting process to take that over in terms of supporting these states, some of which are using that model robustly and look around for economic evidence, not only in prevention, but in a broad array of areas. But also simultaneously, that work is always in jeopardy because if there's turnover or culture change in a legislature or in an agency, that work stops, right? And so the key here is that this is why we need an ongoing relationship between the scientific and decision-making communities. And I use the example of, in the substance use space, we once upon a time thought just sharing knowledge about how bad drugs was going to make the difference, right, with kids and with families, and and then we realized no, that's not what it takes, right? That might be part of it, but that is not how we achieve real behavior change and break these cycles of how substance misuse begins and how it ends. So I think we have to think about in the same way that there's an opportunity to engage with these policy communities and support their own behavior change around how they prevent and support their communities around substance misuse.
Oh, that's really good. And I remember, I can't remember his last name, but the person in Washington State who was really responsible for starting was Kenneth somebody, Ken Stark?
Steve O's.
No,
Steve
Steve
O's,
O's
yeah.
is Steve O's is the
Oh.
economist, but Ken Stark,
Yep.
I think his name was
Oh,
out
I
there
didn't
in
know.
Washington State, and he really did talk about how this is an ongoing effort. Legislatures change every 2 years, and that's really what made him feel he was successful in this, was he would just go and meet them all, and get to know. So I think that's really. I'm glad I remembered the name. I wasn't sure I was going to, but that's terrific.
Really
so
nice.
That's a long time ago. We have a couple of questions now in the chat and a response sort of about peers. The question is, how can we obtain the data to assist in the advancement of peers in the behavioral health system? And there was one answer here in the chat from the team at UT Health. They're about to present about their pilot cost effectiveness study of peers to cover recovery support. And so there is some work to do that. I'm wondering, in terms of prevention, are peers, I should know this and I don't. Are there peer prevention programs or anything like that that people know about?
No, I don't. My answer is no.
Okay. Maybe
but
somebody in the
do.
chat does. Go ahead.
Okay, maybe
Okay.
someone. I just want to say though that this is such a critical component,
Right.
More on the treatment side, of course. And we're doing some economic studies as part of the Healing Community Study on the costs of peer recovery agencies and the various services they offer. But
and NIDA has just, with the help of the HEAL Initiative, has recently expanded a set of projects that we have on recovery supports. And in my mind, I know it's and again, people know I've been in the field forever and I have my own opinions, but anyway, in my mind, prevention of resumption of use is a really important part of what I think peers are potentially able to do. So some of the projects in that peer recovery support research network are looking at is how we can use peers to help people maintain their recovery and not resume use, or if they do resume use, help them, pick up, and get back to their recovery journey. But okay.
Sarah, I'm just going to
go
put my MC hat on and say we've got a couple minutes left, so we got time probably for one more question.
Okay.
So take it away, Sarah.
All
and
right.
we love your opinion, Sarah.
And so I don't see any more questions
in
the chat or Q&A. Any maybe parting words anybody wants to say before Max takes it away?
Laura, anything from you?
Just that this has been a great panel discussion, great questions. So Max, I'm gonna let you take us away.
All right. Well, a huge thank you to the panel and to Sarah for moderating, and thank you very much to all for attending. Hopefully this has been a fun and engaging hour, and I know it went very fast, and we hope to leave you with the enthusiasm to think about incorporating economic evaluation into your own prevention work. So we've placed a link in the chat to provide feedback on this webinar, and the RTI team will also follow up with each of you with a link to NIDA's website where the slides and the recordings from today can be accessed. It is Friday, so we hope you have a great rest of your afternoon and your weekend. And just a big thanks from all of us here. Really appreciate the opportunity to share this work with you.